Diverticulitis is a diverticular disease caused by inflammation of colonic diverticula and occurs as a complication of diverticulosis. More commonly in older adults, it may remain localized mild, uncomplicated diverticulitis, or progress, resulting in complications such as abscess or perforation. Complicated diverticulitis. Diverticulitis typically manifests with fever and left lower quadrant abdominal pain, as the sigmoid colon is most commonly involved. CT abdomen with Roman 4 contrast is the preferred diagnostic modality in suspected acute diverticulitis. Uncomplicated diverticulitis usually responds to conservative management with bowel rest and analgesics. Oral broad-spectrum antibiotics are reserved for patients at high risk of complications. In complicated diverticulitis, management consists of parenteral antibiotics, treatment of any complications, and, in some cases, emergency colonic resection. Once the acute phase has resolved, a colonoscopy is often performed to rule out malignancy. Oral
broad-spectrum antibiotics are reserved for patients at high risk of complications. In complicated diverticulitis, management consists of parenteral antibiotics, treatment of any complications, and in some cases emergency colonic resection. Once the acute phase has resolved, a colonoscopy is often performed to rule out malignancy. Elective colectomy is recommended for all patients with complicated diverticulitis. That is, managed conservatively. The procedure is not routinely indicated for uncomplicated diverticulitis. Incidence 4, 5, 188 100ths person years 5, increases with age, occurs in 20% of individuals with diverticulosis. Disease burden 4, accounts for greater than 165,000 annual hospital admissions in the U.S. Likelihood of requiring surgery 15%, mortality 1%. Epidemiological data refers to the U.S. unless otherwise specified. Formation of diverticula, most commonly in the sigmoid colon. A combination of increased intraluminal pressure, e.g., due to chronic constipation, and age-related or physiological weakness of the intestinal wall, see diverticulosis. Inflammation. Most commonly, chronic inflammation and increased intraluminal pressure, erosion of diverticular wall inflammation and bacterial translocation. Rarely, stool becomes lodged in diverticular obstruction of intestinal lumen inflammation. Low-grade fever. Sigmoid colon, most commonly affected left lower quadrant pain. Possibly tender palpable mass, pericolonic inflammation. Change in bowel habits. Constipation in 50% of cases and diarrhea in 35% of cases. Urinary urgency and frequency in 15% of cases. Sterile puria. Acute abdomen indicates possible perforation and peritonitis. Rarely hematochezia. In elderly or immunocompromised patients, clinical symptoms may only be mild. Recommendations in this section are consistent with the 2021 American Gastroenterological Association (AGA) guidelines on the medical management of diverticulitis, and the 2018 Joint European Association for Endoscopic Surgery (EASE) and Society of American Gastrointestinal and Endoscopic Surgeons (SAGES) consensus statements on acute diverticulitis management. 6. 9. Approach 9, 10, 11. Suspect acute diverticulitis in adult patients presenting with LLQ pain, fever, and leukocytosis. The diagnosis is typically confirmed with imaging, preferably CT abdomen with IV contrast. Consider obtaining imaging in patients with an unclear diagnosis, immune deficiency, poor response to treatment, recurrent disease for which surgery is being considered. Can defer imaging in patients with a prior history of diverticulitis who have symptoms similar to previous episodes. No signs of severe or complicated disease. Consider colonoscopy to screen for malignancy once the acute phase has resolved and the risk of perforation is reduced. Women presenting with LLQ pain should receive a pelvic examination in order to assess for gynecologic etiologies. 11. Laboratory studies 10, 12, 13. CBC, leukocytosis, possible anemia, BMP, electrolyte abnormalities, bun creatinine, CRP, FOPT, positive in patients with diverticular bleeding. Consider the following to rule out common differential diagnoses based on pretest probability. Urinalysis, to rule out UTI and nephrolithiasis. Urine or serum beta HCG, to rule out pregnancy, including complications of ectopic pregnancy in all women of reproductive age. Stool microscopy, to rule out gastroenteritis. See also diagnostics in acute abdomen. Diverticulitis is highly likely in patients with LLQ, pain and tenderness. No. Vomiting and CRP greater than 50 milligrams. And 6. Imaging 10, 13, 14, 15, 16, 17. CT abdomen and pelvis with IV contrast. 14. Indications. Preferred initial imaging modality for suspected diverticulitis. 6. 14. Diagnostic confirmation in patients with no prior imaging studies. 9. Staging the severity of diverticulitis, see modified Hinchey classification of diverticulitis. Supportive findings, colonic outpouching, signs of inflammation, bowel wall thickening greater than 3 millimeters, peridiverticular mesenteric fat stranding. Complications may also be identified. Peridiverticular abscess, hyperdense collections with peripheral contrast enhancement, diverticular perforation, pneumoperitoneum, intestinal obstruction, dilated intestinal loops with multiple air fluid levels. MRI abdomen and pelvis, without and with. IV contrast. Indications, suspected diverticulitis in patients with contraindications to CT14. Findings, similar to those on CT scan. Ultrasound abdomen. Indications. Formal ultrasound is typically considered as an alternative to MRI in patients with contraindications to CT. Point-of-care ultrasound may be considered as an initial imaging modality and can show findings of complicated diverticulitis, e.g. pneumoperitoneum free fluid abscess formation. Supportive findings, diverticular with surrounding inflammation, hyperchoic, abscess formation detectable fluid, bowel wall thickening, abdominal X-ray. 13. Not useful in diagnosing uncomplicated diverticulitis. Indications. Suspected perforation or bowel obstruction may be performed as part of the routine workup for acute abdominal pain. Findings that may be seen in complicated diverticulitis include bowel perforation, pneumoperitoneum, bowel obstruction, dilated bowel loops, and multiple air fluid levels. Screening colonoscopy. 10, 13, 16, 19. Recommended 6-8 weeks after the resolution of the acute episode to assess the extent of diverticulitis and rule out malignancy. 6-9-10. Colonoscopy is contraindicated during an acute episode because of the increased risk of perforation. Not required if a recent evaluation of the colon has been performed. 19. Avoid colonoscopy during the acute phase of diverticulitis because of the risk of perforation. Sigmoid diverticulitis with suspected perforation. To choose the best treatment approach and determine the prognosis, identifying the stage of acute diverticulitis is recommended. 13. Uncomplicated diverticulitis, localized inflammation of a colonic diverticulum with no evidence of complications, i.e. modified Hinchey stage 0 and stage IA. Complicated diverticulitis, inflammation of a colonic diverticulum associated with complications such as perforation, abscess, fecal peritonitis, bowel obstruction, or fistula formation, i.e. modified Hinchey stages, EBIV 10. The modified Hinchey classification is based on CT findings and is the most commonly used classification. 6. Recommendations in this section are consistent with the 2021 American Gastroenterological Association AGA Guidelines on the Medical Management of Diverticulitis, and the 2018 Joint European Association for Endoscopic Surgery, EASE, and Society of American Gastrointestinal and Endoscopic Surgeons, SAGES consensus. Recommendations in this section are consistent with the 2021 American 9. Approach 11-17-21. Uncomplicated diverticulitis. Modified Hinchey stage 0 and stage IA. Conservative management 13-17. Consider broad-spectrum oral antibiotics, e.g. ciprofloxacin plus metronidazole in select patient groups. Complicated diverticulitis. Modified Hinchey stages IBVIV. Inpatient management with broad-spectrum IV antibiotics is recommended. CT-guided percutaneous drainage for abscesses greater than 4 centimeters. Emergency colectomy in patients with generalized peritonitis. Consider imaging, antibiotic therapy, and surgical consultation early for immunocompromised patients, as they are at high risk of developing severe or complicated disease. 9. Uncomplicated diverticulitis 6, 9, 11, 13, 17. Antibiotic therapy recommended on a selective basis, not routinely. 9, 16, 19, 22. Indications 9, 16, 22, 23. Clinical presentation, signs of generalized infection, e.g. fever, persistent symptoms, vomiting, pre-existing conditions, pregnancy, immunosuppression, frailty, comorbidities, diagnostic findings. CRP greater than 140 milligrams LOWBC count greater than 15,000 mm3. Fluid collection and/or extensive inflammation on CT. Options, consider any of the following broad-spectrum oral antibiotics. 22, 23, metronidazole, dosage, plus one of the following. 22, ciprofloxacin dosage. Levofloxacin, dosage 22. Trimethoprim, sulfamethoxazole, dosage 22. Amoxicillin, clavulanate, dosage 22. Moxifloxacin, dosage 22. See also empiric antibiotic therapy for intra-abdominal infections. Duration of therapy, 4-7 days 16. Supportive care, relative bowel rest, clear liquid diet until improvement of symptoms. Analgesics, as needed. C. Acute pain management. 11. First-line treatment for mild to moderate disease, acetaminophen and antispasmodics, e.g. dicyclomine. Reserve use of NSAIDs and opioid analgesics for refractory pain. Antiemetics as needed. Disposition and follow-up. Outpatient treatment 6. Follow-up in 2-3 days for evaluation of progression earlier if symptoms worsen. If no improvement, consider inpatient management. Repeat imaging to evaluate for complications. Screening colonoscopy after the first episode. Once symptoms have resolved if the patient has not had a colonoscopy within the past year. 6-9. Consider surgical consult for recurrent uncomplicated diverticulitis. GI consultation for patients with frequent recurrent episodes, chronic symptoms or unclear diagnosis, e.g., possible inflammatory bowel disease. 11-22. Patients without severe symptoms or comorbidities can be managed in an outpatient setting if they have uncomplicated diverticulitis. Oral intake is tolerated and adequate follow-up can be ensured. 11. Complicated diverticulitis. 6-11-16-17-19. Complicatum iveric and routinely recommended empiric antibiotic therapy for intra-abdominal infections. Management of complications. Abscess. 13-17-24. Size. Less than 4 centimeters. Trial of conservative management with IV antibiotics. Signs of improvement in 48-72 hours. Start enteral feeds. Consider switching to oral antibiotics. No signs of improvement in 48 hours. Repeat imaging and consider percutaneous drainage. Size greater than or equal to 4 centimeters. Ultrasound or CT guided percutaneous drainage. Consider laparoscopic or open surgical drainage if percutaneous drainage is not feasible. Continue IV antibiotic therapy. Send aspirate or pus for cultures and tailor antibiotic treatment accordingly. Perforation with generalized peritonitis, i.e. clinical signs of diffuse peritonitis or modified Hinchey stage 3 and stage 4 on imaging. Emergency surgery. 6-16-17. Hemodynamically stable patients, laparoscopic or open colectomy and primary anastomosis without a temporary diverting stoma. Critically ill patients, Hartmann procedure, bowel obstruction. C. Treatment of paralytic ileus. C. Management of bowel obstruction. Supportive care. Complete bowel rest, NPO. IV fluids, C. IV fluid therapy. Analgesics as needed, C. Acute pain management. Antiemetics as needed, C. Antiemetics. Disposition and follow-up. Inpatient treatment with surgery and/or interventional radiology consultation. Screening colonoscopy once symptoms have resolved if the patient has not had a colonoscopy within the past year. 9. Consider surgical consult. Critically ill patients, Hartmann. Ill patients, the surgical resection of the rectosigmoid colon, followed by creation of an end colostomy with closure of the rectal stump. Usually an emergent temporary procedure to treat bowel perforation, infection e.g. diverticulitis, or obstruction if primary anastomosis is deemed unsafe. Can be permanent when carried out as a palliative measure for colon cancer. Diverticulitis is a diverticular disease caused by inflammation of long-term management, elective colectomy. 10, 13, 17, 19 indications, routinely recommended 6-8 weeks after resolution of complicated diverticulitis. Select groups of patients after resolution of uncomplicated diverticulitis, including 13, 16, 17. Patients at high risk of recurrence with complications. 13. Patients with persistent abdominal symptoms after resolution of an acute episode. Chronic complications of diverticulitis, e.g. fistula, colonic strictures. Procedure, laparoscopic or open colectomy. 13-16, secondary prevention, reducing recurrence risk. 9-16, 19. Avoid non-aspirin and NSAID use if possible. The use of mesalamine, rifaximin, or probiotics to prevent recurrences is no longer recommended. 9. See prevention in diverticulosis. See prevention in diverticulosis for primary prevention to the formation of an abscess or phlegmon. 20. Intraperitoneal perforation caused by rupture of an inflamed diverticulum. Free communication with the peritoneum. Generalized fecal peritonitis. Rupture of a diverticular abscess. Generalized purulent peritonitis. Can present with symptoms of acute abdomen and widespread intraperitoneal free air on imaging. Abscess. Peridiverticular localization. Peridiverticular localization causes symptoms. Etiology. Narrowing due to inflammatory swelling. Compression through abscesses. Ileus caused by localized irritation. Clinical findings. Abdominal pain and distension. Constipation. Nausea. Vomiting. Acute abdomen. Bleeding. Although diverticular bleeding occurs commonly as a complication of diverticulosis, it does not frequently coexist with diverticulitis. 25. Pylophlebitis, most commonly affecting the superior mesenteric vein, portal vein, and inferior mesenteric vein. 20. Late 20. Fistulas. 26. Epidemiology, most commonly colazical. Other forms: colovaginal, coloenteric,